First of all, thank you very, very much indeed for coming. You could all be propping up the bar right now, and I worry that if I were you, that is where I would be. You've had a long day, and this is not an easy topic to engage with at the end of it. This is a crisis of ferocious complexity. And so we're very grateful from MDM, we're very grateful that you're all here and a receptive audience willing to listen and to hear some stories that are pretty difficult to hear. I think my role really is to introduce our three speakers, all board members from different parts of Médecins du Monde, doctors of the world, from different chapters. But I wanted to sort of frame the issue. You are in many ways a wonderfully receptive audience to talk to about humanitarianism and about the crisis in Europe, because you are steeped in the humanitarian ideas because of your work in healthcare. Healthcare is grounded in the provision of care on the basis of need rather than anything else. And so you're already upholding that first central humanitarian principle. And the other thing that MDM is of course concerned with is the right to health. And the right to health is one of the most universal human rights because, of course, as you all know, health is dependent on so many other aspects of your life, your education, your income, your freedom to move, and so on. And so we are an organization that is deeply grounded in human rights and in humanitarian principles. To give you an idea of how complex this crisis is and how difficult it is to provide healthcare in this crisis, I just want you all to imagine a camp, and I want you to imagine running a refugee camp. Frequently we're asked to imagine being in a refugee camp, and being in a refugee camp is usually pretty bad, but if you imagine running it, I think you get a very clear idea of the complexities that healthcare providers face. Because in order to provide high quality healthcare, you would need a camp that has water and sanitation, organization, electricity, and security. You would need to register everyone, and that is the basis of the way that every serious modern nation provides healthcare. People are registered, and you govern the population through healthcare. The difficulty is that this is a population who don't want to be governed in camps in those ways, because if you're providing high quality healthcare and restricting their movement, you are doing something that is adverse for the refugees in many ways. And so there is a fundamental tension between letting people move, giving people the freedom to seek the lives they want, and creating the conditions in which excellent healthcare can be provided. And that is the tension that MDM tries to resolve. So I hope I'm sure that our next three speakers are going to be able to do that. Our first speaker is Professor Anders Björkman. He is the Vice President of Médecins du Monde, Sweden, and he's also medically responsible for the clinic run by MDM for undocumented migrants in Sweden. He's a professor at the Karolinska Institute and has for many years been a clinician. Apart from his work with MDM, he is also trying to eradicate malaria from Zanzibar and has a long and august history of publications and work in infectious disease. So we're very lucky to have him in the organization, and I'm very much looking forward to hearing him tonight. Anders.
Thank you. Yes, I will try first to give an overview picture of the issue of healthcare to the migrants, and also what the network of MDM, Médecins du Monde, Doctors of the World, have undertaken. And then you will hear more about some pictures from the groundwork in the follow-up speakers. As you've heard this many times about the huge displacement issue that we have at the moment with millions of refugees. And to respond to that, the Médecins du Monde has as a priority, as one of the priorities of Médecins du Monde, is to assist in the healthcare issues in relation to the large global displacement. We do have 430 programs total in over 80 countries. That's of course not only refugee programs. And in 15 countries have national programs, so MDM, Doctors of the World, exist in 15 countries, one being Sweden, and where we run both domestic programs and international programs. And here is a picture of the MDM and partners that are involved in the crisis, or let's say the refugee problem that we're seeing at the moment. And as you can see from the picture, from the graph, or let's say the map, there we are in many places. We could say from the country of origin, be it Syria, for instance, up to the end station of the refugee, of the flight from the disaster situation all the way up to north. Most north is Sweden. Just to summarize a little bit, we see, you've seen this, these figures, about 60 million displaced people in the world at the end of 2014, and only in 2015, over the Mediterranean, we saw over 1 million migrant arrivals. And this has not, although in Sweden we have somehow stopped it, this continues in the Mediterranean Sea. So already now during 2016, we've almost seen 200,000 refugees coming, and mostly ending in Greece as a first sort of entry point. These are children, women, men. And we have unfortunately already experienced that the deaths continue to occur in the waters, 711 so far this year. All of them, almost all have experienced conflict and war, of course. 49 coming from Syria, 26 from Afghanistan, and 16 from Iraq. What we experience is that 84% of them have experienced physical, psychological, or institutional violence. And this is a recurring theme on their journey from the conflicts they have fled, and all the way through the transit and back into their host countries. So, as I said, Médecins du Monde, Doctors of the World, are from, actually we are all even in the countries of origin, but we are there to assist where at the main entry point and during transit towards the exit points. One of these mostly frequented first entry points is Lesbos. 60% of new arrivals will come to this island in Greece. And we are there to provide access to healthcare, mental health, and psychosocial support. Another place which brings a lot of a major entry point for the migrants or refugees is the Chios island, where we have, and I should have said maybe also we have both have clinics at the point of arrival, and we also have mobile units. These two islands are the entry points, but then of course this is only the starting point for their travel within Europe, and the main continuation is through a ferry to move further towards Athens. And there MDM has also a specific ferry project where we bring and assist during the transport up to Athens and other places. And again, this provides an opportunity to assist in this very difficult situations that we see are refugees. Then in Athens, as an example, there are clinics, and actually here we work, we have many of the clinics are purely MDM, but we also work with the local health structures. We're happy to be, from the fact that in Greece, Médecins du Monde Greece, MDM Greece, has a long-standing activity for different populations who have difficulty in access to ordinary health care. If we move further up east, we have one special place at the border of Macedonia, a difficult situation, where we also have major activities. And here we can see there's been what sort of patients we have. It's mainly respiratory tract infections, diarrhea, vomiting, skin diseases, and of course trauma, which could be both psychological trauma as well as more surgical type of trauma. In addition, which other organizations have also, we do assist along the sea, the Mediterranean Sea, with a medical team on one of the ships. Another place you may have heard of is for those refugees who want to move further to UK, and where there has been disastrous situations because of course it's extremely difficult to move further from France to UK, and there are huge camps, one being in Calais and one in Dunkirk. And here again, there's enormous needs of medical, socio-legal support of different kinds. I said trauma is as one of the major aspects, and we both experience trauma in the countries from where they come, which could be different from the conflict that is there, and it could be, for instance, wounds and associated complications, but it could also be from previous torture. But, which needs to be remembered, even during the transit situation, there is a lot of issues like accidental injuries, hypothermia. Of course, the situation for staying overnight is not appropriate. Dehydration, burns, and unfortunately, deaths of friends and family members require psychosocial support. With regards to the health status, we do try to, in all our activities, try to sort of investigate and have statistics to be able to sort of, because we always want to witness also what we see. Come back to that. And what we do see is that 23%, or around 1/4 of all the patients perceive that their physical health is bad or very bad, and about the same when it comes to mental health. Very few or many have not been able to get any medical attentions where they are. Now they are in Europe. And 10% of patients with chronic condition only knew their diagnosis before coming to the MDM consultations. So obviously the healthcare in their home countries, for obvious reasons, have been extremely poor. 10% report having been have been victims of violence after arrival in Europe. Two groups of people which we're always concerned with is, of course, children and pregnant women. And as an example, we can see that the immunization status of our children is far below what it should be. Between 58% and 66% were not immunized against MMR, whooping cough, hepatitis B, or tetanus. And interestingly enough, having been a lot in Africa, for instance, these are worse figures than in African poor regions. 40% of parents did not know where to go to have their children immunized when they came. So, and this is just to compare with our figures, which are, of course, above 90%. Another important and critical group is, of course, pregnant women. More than half of pregnant women had no access to antenatal care before they came to MDM. And they don't have, which is important, no legal rights of having their health coverage when they are in the EU. Such is the situation. Okay, just a final message from all our volunteers out there working and seeing all the situations. They want to express that daily they see that humanitarian rights are not considered. The rights of asylum, the rights of health, the rights of health care are violated on a daily basis. The verdict of the history verdict will be harsh and severe. Remember what I said.
Hear, hear. Thank you for that spectacular overview, which is pretty grim viewing. The next speaker is Dr. David Montes Bentura, who's from the MDM Spain chapter. He's a pediatrician, originally a neonatologist, now an endocrinologist, and he volunteers both in Spain and internationally. He's one of many people in MDM who give up their time on a regular basis in their hometown to work with marginalized population with an NGO. I think in many ways it's quite easy being an expat overseas. To see vulnerable populations close to home, this close to home, is spectacularly difficult. He's been working in Greece and he's going to tell us about that now.
I'm going to talk about my experience in Chios Island in Greece. Our work under the umbrella of Doctors of the World Greece. It was a pleasure to work with them. And these are the migrant routes that were followed in 2015 in Europe. And when you get to the island, the most impressive and difficult thing to understand is why these people are risking their lives and their families' lives just to cross these 4 kilometers from the Turkish border to get to Europe. And you can understand it when you listen to the stories they tell you and tell you what are they leaving behind, the war, the dramatic situations they have. So you start to understand them, but it's the moment when you realize that the real dramatic stories are those that we will never listen to, are those stories of people who have lost their lives in the Mediterranean Sea. For these 4 kilometers, thousands of people have died last year, and they lost their lives in the Mediterranean, and probably many more will die if things don't change in next months. Our first claim from Doctors of the World is to ask for a safe passage for these people, because this would be the way to save their lives. What we find when they reach the coast, the main worry we have is the hypothermia, because when we have to warm them, get them blankets, hot drinks, and do whatever to get the temperature of the body okay. And all the things that we have to attend there are also trauma or respiratory tract infections. But probably the most difficult thing to attend are the psychological impact of this stressful situation, because I think not many people is prepared to know how to deal with these situations and these and this, when you face these people in the seashore. These are pictures of the registration points. When people get to the coast, they're taken by the police to the registration points are in Chios, Mersinidi, and Tabacica. And as you can imagine, these are not friendly places to welcome them. They have to spend in these places days or sometimes weeks until they get registered, depending on the administrative situation in that moment. And when they finally get registered, they can pass to the refugee camp. This is the refugee camp where I was working, is Suda camp. I like to call it like a 5-star refugee camp, but not only because of the conditions, but also because of the people who were working there with a great coordination and doing a great job. I'm so glad to have been part of this. But this is not what impressed me more. For me, the most impressive situation, what I found, is the Greek volunteers' role in this crisis. These people have been working, dealing with this situation for years now, and I think they're giving us a lesson of how to deal with human rights and the dignity of people. And maybe we should question about other Nobel Prizes given before, and I think the European Union has a lot to learn from these people. What happens? Thank you. What happens when they get to the camp? When they get to the camp, they are always looking for get some rest, because it's not only the physical tiring that they have, it's also the stress situation in what they find themselves. And the truth is, when the camp is crowded, there is no room enough for everyone, and some people have to sleep outside. This is very difficult also to get the dry clothes overall for the children, because when it's raining, there's no way to get the dry clothes. And this is the main problem for the respiratory infection, which is the first consultation we attended in the clinic. But apart of this, you could feel in the camp the anxiety they have to contact with their families, because when they started the trip in their countries of origin, they know this is the critical moment of the trip, is where they're going to risk their lives, and they have their relatives dependent to know if they're okay and they're still alive. So this is a dramatic moment of when they get to the camp, when they contact with the family. And this is our clinic, a small clinic where the international team of MDM were attending these people who sometimes had to wait for hours until for the medical attention. We were working with people from Holland, Greece, and Spain, and it was a multidisciplinary team where nurses, doctors, social workers, and also the translators, because without the interpreters, I cannot imagine how to make diagnoses or how to explain how to give the treatments to the families when you have the diagnosis. What to do now? What we found in the very beginning is that we could attend in a proper way the acute illness. It was a primary care attention, but we have a lot of difficulties to attend the chronic diseases and the severe diseases. And this is the point where what can we offer them now when they come? We think it's basic to have a medical record of what is going on, because when they get to the seashore, they lose everything. They don't have the medical records from their countries, and this is something that we have to do now for them. In the case of the children, it's basic to have the vaccine schedule, the nutritional situation of the kids, and and to know about the chronic diseases that they have, about what we found in the most severe things we have found were the congenital cardiac diseases and also the type 1 diabetes. So it was difficult to know how to treat this. Imagine in your daily job, if you know nothing about that, it's difficult to decide what treatment to give to them. So it will be very useful to get this record, but not only for children, also for pregnant women who were with a big anxiety because they didn't know if their babies were okay. So I think it would be basic to have to know how many weeks of pregnancy, to know when is the expected date for delivery, if there is any illness, hypothyroidism, diabetes, whatever, and what treatments they are or they should be on. For the chronic disease, also we should know for these patients the allergies and if they are diabetic, hypertension, heart diseases, oncologic problems, what treatments they are on and what acute illness we are treating in the way. We have to think that only the things we will record is very important information for the next point when they will be attended. But all that we have talked about has changed since the agreement between European Union and Turkey, and we don't have more humanitarian aid in Chios. Actually, we have, it has become a detention camp in Vial. This camp is ruled by the police and by the army, and the human rights on medical assistance is not guaranteed inside. So from Doctors of the Wall, our challenge now is to defend and guarantee the right to health of these people and try to give them the proper assistance to these people who are in transit and they're in nowhere place. So thank you very much.
Thanks, David. So our next speaker is Dr. Hanna Ingelman-Sundberg. She is the youngest MDM Boardman member that we have. She's a junior doctor in Stockholm, and she also volunteers. She is also, as you might notice, pregnant, and she is putting in huge numbers of hours, and this is what this kind of care relies on, people who are prepared to undertake significant amounts of work in their spare time to try and raise awareness and deliver potentially life-saving care to these populations. She's going to talk specifically about MDM's work in Sweden. Thanks, Helen.
Thank you very much, Alexander. I will try to give an overview of how MDM Sweden encountered the refugee crisis. But I will start by giving a short introduction to Läkare i Världen, MDM Sweden. We were founded in 1991 and started the main project, namely the Voluntary Medical Clinic, in 1995. Initially, the clinic only worked with undocumented migrants who at that time did not have at all access to regular health care. In 2013, the legislation in Sweden changed so that also undocumented migrants now can have access to subsidized care. This made us change the way the clinic works. So we currently provide health care for EU citizens without proper health insurance. And we still work with undocumented migrants with legal advice, psychological support, and also to help them to get the access to the care they are entitled to. Our medical clinic is situated in Stockholm. It's open once per week and uses 4 doctors, 3 nurses, and 1 dentist per evening. And we see approximately 20 to 25 patients every time. So Sweden faced the European refugee crisis in September, and in Stockholm it arrived September 11th when the first trains came. There are no reliable numbers on how many that arrived, since many continued to neighboring countries without being registered. However, according to official numbers, more than 114,000 asylum applications were handed in between September and December 2015. MDM Sweden very early realized that one of our main tasks was to prevent disinformation, because a lot of the volunteers turning up at Stockholm Central Station, partly from other NGOs, partly spontaneous volunteers, were not aware of the legislation entitling also undocumented migrants and asylum seekers to governmental care. So our first task was to spread out a leaflet with the correct information, and we managed to spread more than 1,000 copies to different volunteers only the first 24 hours after the trains arrived. This document was later shared on through social media and also through paper copies and reached a large number of volunteers. Then, as in any refugee crisis, the main challenge is to identify the most emergent and immediate needs. So what's needed was to find patients with life-threatening or other very serious conditions in the whole group of newly arrived people. So how we managed to do that was that we set up a mobile team of medical staff who could visit both arrival points and the preliminary refugee shelters and conduct primary service of people wanting to seek health care. We were then able to take patients with serious conditions directly to hospital and treat also lighter conditions on the spot. The mobile team initially moved through subway and buses, carrying a bag of medical equipment. However, we sooner got access to a car which we could provide with some more basic medical practicalities. And by phone, we could keep in contact with the main refugee shelters to relocate our volunteers where they were mostly needed. In 2016, we faced a new situation. The Swedish government decided on temporary border controls from January the 4th. This means that all travelers wanting to enter Sweden need to show valid documents and proof of identity. And this has led to a serious drop of arriving refugees, which means that according to official numbers, only 9,000 asylum applications has been handed in during the first 3 months of the year. This made us change the way of how to work with the mobile clinic. I already mentioned that the medical clinic in Stockholm works with EU citizens without proper health insurance. So now we used our set-up mobile clinic to visit the shelters for EU citizens without proper housing. However, we can still assist also newly arrived refugees after contact with the asylum shelters if needed. And the mobile team is active every weeknight and seeing around 10 people every night. Our main challenge for this year is new legislation in Sweden severely impairing asylum rights. And we have raised great concern about this new legislation because we know that this will affect people's health. People already under a large pressure will get their rights violated and be prevented to seek shelter. And we will act as a watchdog to report how these impaired rights affect the health status of people. And this week, we will start a new campaign where we encourage people to witness about what they see and not to stay silent about violations being made. And I think this image summarizes what we want to say from MDM. And I give over to Alexander.
Well, thank you all for staying so long and listening so patiently. I'll just leave you with this. Susan Sontag, who's an American photographer, critic, playwright, in writing about how we react to the suffering of others, said we must try to locate our privilege on the same map as their suffering. Médecins du Monde is the only medical NGO that cares for refugees from the moment they arrive in Europe all the way through the journey and then into their eventual host countries. I visited many of these projects as an MDM board member. And the sense I had from this crisis is of a global reckoning, that there is a massive north-south inequality which is totally unsustainable. And whether the migrants are refugees or in some cases economic migrants, they're coming from places that we have benefited from being vastly unequal to. This is not a zero-sum game. They're not coming to take our jobs. They're not going to overrun Europe. They can flourish and we can flourish at the same time. It's possible to keep people healthy in a camp, but it is not possible to have a full, rich, flourishing human life in a camp. And that's why MDM has to work in advocacy and in multiple other ways as well. Thank you so much for listening. Thank you for your support.